Hey, GLP-1 plus size community. Before we jump into the podcast, please take the time to leave us a 5-star review on whatever audio platform you're listening to the podcast on. Share your story and how the podcast has helped you. This will help us get referred up in the audio platform so that we can reach more people that need our help, our support, and guidance from our doctors. Help us get loud and change things. Are you interested in understanding GLP-1 medications like Ozempic, Wegovy, or Mounjaro? Then join us on the Plus Sides, Cracking the Obesity Code, the groundbreaking podcast helping people change their lives one episode at a time. The Plus Sides podcast is a disruptor. We're breaking down barriers, smashing stereotypes, and sharing inspiring stories that'll leave you feeling informed and empowered. Join us every week to learn from doctors who are specialists around GLP-1 medications like Ozempic, Wegovy, and Mounjaro. They'll provide you with science and facts to validate these incredible stories. But that's not all. We'll also bring you the voices of the GLP-1 Mounjaro TikTok community, real people who face the challenges of obesity-related diseases and disorders and discovered the incredible plus sides of GLP-1 medications. Our episodes are filled with heartwarming stories, laughter, and moments of triumph. You'll connect with our amazing community members who are reclaiming their health and experiencing their fullest lives. Are you ready to embark on a journey of discovery and empowerment? Tune in to the Plus Sides, Cracking the Obesity Code, and together we'll change the narrative around obesity and end the stigma. Subscribe now on YouTube or your favorite podcast platform and join our incredible community. Let's celebrate the plus sides of life together because every story deserves to be heard. Every life deserves to shine, and everyone deserves access to expert knowledge and medication. The Plus Sides Podcast. You're not alone. It's not your fault.
"20 seconds a week to lose 20% of your weight in a year with diet and exercise. That's the power of GLP-1s through Ro. Ro helps find the medication that's right for you, based on cost, availability, and your weight loss goals. Losing weight with GLP-1s is possible through Ro.
I think I have a question. So I know we were talking about clinical studies and things like that. My mom actually just got diagnosed with lupus. And one of the things that I did was did a whole bunch of research. This is when I was heavy into GLP-1s, nerding out. And I saw that it has a lot of anti-inflammatory properties. And so I convinced her to try semaglutide, and she's been on it for, I would say I think she's coming up on her 6 months. Wow. And it's completely changed her whole life. She hasn't lost that much weight, but she wasn't obese, but she was definitely in the overweight category. So she qualified, but her inflammation has gone down significantly. Her lupus was affecting her so badly that she could barely walk, and they were talking about putting her on a cane.
Oh. Wow.
And now she's walking for miles. She went to the doctor and was doing squats. So I wanted to, she was doing squats. She was like, look at what I can do. And let's do squats.
I'm excited for her.
Best. Yeah, that's awesome.
Good for her.
Yeah.
I want to say the reason that happens is because fat is not just sitting there in our bodies making us, feel uncomfortable. It actually secretes a lot of hormones, and some of the hormones that it secretes are inflammatory hormones. Mm-hmm. So that's why you see all this inflammation when people have more fat cells, right? Mm-hmm. And so if you can reduce the amount of fat cells that they have, and also reduce how much inflammatory stuff is being produced, then that's why diseases like lupus get better, because you do have that less inflammation because fat cells produce inflammatory hormones.
Oh, okay. Because I couldn't figure it. I was just always so curious about the anti-inflammatory piece of it. And so in the future, do you think these drugs will be approved for these diseases? Or
and actually, all of the pharmaceutical companies are working really hard at getting an additional indications for them, because it's really frustrating. Really, we don't recognize obesity as a disease. I had a patient today tell me that the insurance rejected the labs because I coded obesity. So he got an $800 bill. $800 because I coded obesity. So I had to call and say, okay, they have insulin resistance and all these other things, because you can't just code obesity. It's not It's not recognized. And then a lot of clinics, when they talk about billing, this is like some doctor provider stuff, but basically you can't code obesity if you want to get paid. You have to code all the diseases associated with obesity.
Yeah.
It's bad. Like they really, and that's why in my channel I talk about obesity is a disease, obesity, because we have to keep saying it so people get it, right? That this is not just like, oh, I didn't want to work out today. It's real a problem and it needs to be treated.
And Dominique, I don't know if you've listened to it or not, but we did an episode where we talked about the Senate hearing that me and Kim went to. And one of the cool things for both of us while we were sitting there was listening to the senators in the committee talking about all the different things that lead into and kind of play off of obesity, as well as just other things like, talking about Alzheimer's, talking about dementia, and all of these other diseases and disorders that are being helped, whether it's in a large way or a small way, but being helped by these medications. So it sounded like when Mr. Jorgensen was speaking, it sounded like they are researching a ton about all these other benefits of these medications. I really believe that, eventually they're going to be used to treat so many things, because just as somebody with multiple issues, I notice the stuff that I feel better with. And if I feel better with it, I can't imagine what else it helps out there.
No, seriously.
You're right about that. It's also a big class of medication. So now that they've discovered this class and they see the potential, they're discovering specific medications for, like he said, like dementia or MS, and there's one for liver disease as well, because there's a very high rates of fatty liver disease, which is a metabolic issue, and so there's a specific GLP for that. So they're really starting to tailor the GLPs for different diseases.
That's great. That's awesome. Speaking of, I know you mentioned something about inflammation and fat holding hormones, right? There was that study that came out recently about adipose tissue remains. I don't want to try to say this correctly. Retains epigenetic memory of obesity after weight loss. So I'm asking, in short, if you could kind of expand on that. It's basically, it sounds like our bodies always want to be bigger. Like our fat is remembering, or our fat tissue. I'll let the doctor talk about it, because I'm a communications major, yeah.
So basically they did this study where they took fat cells from people who had never had a weight problem, right? So people who were thin their whole life. And then they took fat cells from people who were significantly overweight. And then they followed those people after they lost weight, either through surgery, medication, whatnot. And they lost significant amount of weight. Like we're talking like 25% of their body weight. And then they compared they looked at the cellular level, what the cells were doing. And what they noticed is that even though at the end of the day, both the thin people that were always thin versus the thinner people who had obesity, which I don't like to say you have obesity. Once you have it, you always have it, right? Because you're going to deal with this battle like your whole life, unfortunately. So what that paper showed was that when you, even if you lost the weight, your fat cells still acted the same way as when you were heavy. And so, so basically it confirmed that just because you've lost the weight, just having been heavy before kind of has such a big impact on your cell function that those cells don't work the same way. And so that's why people continue to struggle. And then there's that whole set point theory about how once you're, at a very high weight, your body wants to stay at that weight. It's like a thermostat, right? It's like almost like a broken thermostat. Your body's just stuck at that highest temperature, and that's where it wants to be no matter what. So even if you lose the weight, it just makes it so much harder for you to stay at that weight. That's why
Your body's
people
always fighting. Yeah.
And that's why you see people with the yo-yoing story, right? Like, and you have so many guests on here that come and share a very similar story
Yeah,
than
we all
yours.
yo-yoed.
They've lost the weight. They did great for a few years, and then I think for you it was pregnancy, right? And then you gained it all back, right? And so it's because your cells still function like somebody who had obesity, even if for years you were at a healthy weight.
You know, you mentioned set weight. I know that we talk about that a lot on this show too, when we get to a certain point where you just can't also like maybe just lose more after that point. Your body is just getting very comfortable at this point. Is it possible for us to sometimes, can a person actually push the needle and get past that set point, or just let's just be happy at the set point?
Okay, so it is possible, but I think what I've come to realize in my practice is that some patients need more help than just one medication. So sometimes I have people on multiple medications. Sometimes we do have to talk about surgery as well as an option, because that's how difficult obesity is to treat. It's like sometimes it's just not about one. It's like blood pressure. Some people can do well on one blood pressure medication, and then we have people that are on 3 or 4, right, to get their blood pressure down. So it's the same thing with obesity. Some people just need more help. So I never like to give up on my patients. I'm like, okay, let's just try something else. But plateaus are normal. And so I do tell people to expect those, especially after losing a lot of weight in the beginning. It is normal for the body to plateau. And the new trial on tirzepatide or zepbound showed that, is that those people were followed for 4 years. And you saw it, like after the first year, most of them plateaued out. Like they stopped losing weight.
Dr. Galindo, with kind of that in mind, and also what you said about the fat cells from the study, do you believe that we are trending in a medical way to where maybe that change in the fat cells in our bodies could possibly be reverted or reset? Do you think that that's something that could be done, or are we looking at something that's more of a permanent change?
I think as we get more advanced in science, right, and we find out more about how these mechanisms work, we can target medications to those mechanisms. But there's also like gene therapies and things like that. So I think it's complicated because I don't think it's going to happen right away. But sure, you know, like one of the talks I went to that I thought was very interesting this past month was like somebody was talking about pancreatic cell transplants, where they wanted to create like these cells in the pancreas that made like these special GLPs. Anyway, so it just, yeah, I just think it's a little bit more, you know, there's a lot of science going out there that where it could be possible, but I don't know if we could reverse it fully. I really also want to focus on prevention, right? Like I think one of the things that we talk about sometimes is like, why are we waiting to treat people until they're 100 pounds overweight? Why not treat them when they're only 30 or 40 pounds overweight? You see what I mean?
Yeah. And do you think there's a path for, or I guess not, do you think there's a path, but kind of what does that look like in how you practice and treat people? Like if I had come to you, for example, when I was, 250, 260, kind of what type of treatment path do you look at to kind of help prevent that from going to a higher weight and then becoming obese and then needing to be on these medications for life?
Sorry, I have kids.
That was the most adorable little appearance.
I know, that was so
that was adorable.
Sorry, can you repeat that last part of your question?
That's fine.
Yeah, no worries. I'm sorry. Like how do you approach treating somebody to prevent them from going to the obese side, to needing to be on kind of GLP-1s? What type of treatment do you look at for that?
So I personalize I have the ability, because I have a micro practice, I actually get to spend a lot of time with my patients. So I'm able to really personalize their treatment plan, right? Because it's not the same if somebody has 100 pounds to lose versus somebody only has 30 or 40 pounds to lose. And then people have different medical problems. So one thing I really do is personalize your care treatment, and also work with the patient and make them realize, like, one, this is not your fault. I show them a lot of compassion because I do think that in the medical field, we have, gaslighted people a lot about this, and there's a lot of bias. So I think I just work with people and just make them realize, like, this one's hard for people, but a lot of people come to me and tell me, hey, I know once I lose weight, then I can get off of the medication. And I kind of have to tell them, like, you might not be able to. And that's hard for some people to come to terms with.
So. Gotcha. Okay. Well, we've been hearing the notion of calorie restriction on how to lose weight that can actually lower your basal metabolic rate. That's been kind of on around TikTok. Do you give your patients a range while taking a GLP-1, or we just kind of use your best judgment?
So I think because I struggled with my weight my whole life, I actually am very anti-diet, and I tell patients that. Like, I mean, yes, I can calculate macros for you if you want. I've, taken courses to learn how to do all that. But I have found that most of my patients, because they have dieted forever, they actually kind of do know what to eat. So I just focus more on, like, okay, we're going to really focus on your protein. We're going to focus on your fiber, right?
Yeah.
And then calorie wise, if they want a calorie restriction, yes, I kind of give them guidelines, but I also feel like some of my patients already have such big suppression from their taking a GLP that I don't want them to not eat either. Because something that I've noticed happens is people will not eat for the first 3 days after their shot, and then on day 4 or 5 they're like, oh, I'm really hungry. And I'm like, yes, because you didn't eat anything for 3 days, so I want you to be eating everything.
That was you, Dominique.
Yeah.
Yeah. And so what happens is when the medicine wears off, your body's like, oh, you didn't feed me. Right? You didn't feed me. So now you
like day 5.
So I always tell patients, like, you have to eat consistently, because if you don't, then that's why you're hungry at the end of, like, before your next shot. So and then that kind of, puts you in this weird pattern of diet culture restriction. And
I'm kind of a weirdo when it comes to that, so I didn't really have a version like that, but it always I get the wall when it's good enough for me. It's good enough for me. So
food has definitely been a very dominant voice in my head. That's not the main focus anymore. Dieting, exercising, and adding GLP-1s through Ro is a game changer. I have such a sense of mental freedom since I started with Ro. Food no longer controls my thoughts. Family time used to revolve around food, and now it revolves around what we're going to go do together.
Yeah. So we have a lot of people in the community, a lot of the community members, they have reservations in regards to, like, doing semaglutide over tirzepatide. And then, of course, everybody's kind of getting nervous over the idea that, the compounded version of tirzepatide may no longer be available. We may lose access to it depending upon, what the FDA decides on. I believe it's the 21st.
Yeah, that's just a few days.
Yeah, just a few days. I know a lot of people are pretty nervous about it. Can we go into a little bit more detail in regards to how semaglutide works and how, it would affect patients as they make that change from tirzepatide to it if they have to? Yeah, I'm sorry. I'm tongue-tied. I can't say these medical names.
I get it. Yeah, we know what you mean.
Whenever patients come to me in my first appointment, I always say, we're going to give you what your insurance covers. Okay. So if your insurance covers semaglutide, or if that's all you can afford right now is semaglutide, right? It's still a good medication. It's still going to help you prevent that regain. So even if you're nervous about losing tirzepatide, just know that semaglutide is still a very good medication. It's the OG, right? Of these medications. It's like, so it's not a bad medication. It just, what happens is tirzepatide came along and the numbers looked better, but it's still a great medication. The other thing is, if you're seeing a specialist, they should be able to help you with other medications if needed. So, like, not everybody needs a GLP for maintenance, for instance. Some people can transition to other medications that we have that are more affordable, that are pills. And so that's kind of what I would tell patients, is not to be nervous if you have to move from one medication to the other. Liraglutide is also an option for people, right? It's Saxenda is generic, and I'm hoping that in the next few months the price keeps going down. I heard that right now you can get a pen of liraglutide for like $300 as well. So, you have options. And I think at the end of the day, as long as you know that you have tools that can help you, that's the most important thing.
What about just kind of to piggyback off of that, also kind of what about like the side effect part of it though? Because like I know Kim and a couple other people within the community that I've at least that I've heard it from have mentioned experiencing like more side effects on semaglutide versus tirzepatide. Can you provide any insight on why that may be?
Yes.
And if that's something that people should worry about a lot, or if kind of like with other medications, those side effects will kind of not necessarily wilt down, but get better.
So the reason you have less nausea with the GLP is because of the GIP component of it. So that's why people have less nausea on it, because that like counteracts the nausea a little bit. And so because semaglutide doesn't have that, people do tend to have more nausea with it. But that's why it's so important also to start low and go slow, right? You don't want to push yourself too hard on these medications. You don't want to start on the highest dose of semaglutide. You might want to start on a lower dose. And that's where your doctor helping you through that is really important. Like, and I always tell patients, like, reach out to me if you have side effects. You need a little nausea medication, or we need to talk about other ways that you can prevent the nausea, then, I'm here for you. So there are ways to help you with some of those side effects too. So I don't want people to be nervous if like they're losing their tirzepatide, because semaglutide is a good option, but you have other options as well.
And then just one last thing off of that. I'm sorry, Kat. For those of us kind of like myself who have adversity to talking to people, or even just you have the adversity to going to the doctor, what type of things can you offer us to put in our tool bag for those occasions to help us talk about that side effect? Because there are a lot of doctors out there, at least from what I've heard within the community, to where as soon as you mention that you have you have the nausea, you have a side effect of any kind, the first thing a lot of these general practitioners go to is, oh, well, we need to pull you off of that. Oh, we need to change, that, where they may not be giving people enough time to work through the side effect. What are some ways that we can talk to our general practitioners or our nurse practitioners about these side effects, to where we're not pulled off of the medication that we need, but things are done more gradually, or possibly we're given something else?
So one thing that I think is very important is to be specific about like your nausea, right? So like if you're having just a little queasiness and nausea, that's not too severe. But if you're telling me that you can't hold anything down and you've been puking all day in the bathroom, that's a problem, right? And so the other thing about being a hospitalist, I've had those patients that I've admitted with because they take their GLPs and they can't pass anything down. And a lot of the times that I see this is when people overdose. So the dosing is very important too. Like, so a lot of patients think, oh, well, I'm losing weight, maybe I should just take more. No, you're supposed to dose it weekly. You should not be dosing it differently. So for your question, I would say just advocate for yourself and describe exactly what you're going through. If it's just a little nausea, some Zofran might help, or some other antiemetic medication. And advocate for maybe just going down to the lower dose if you were doing fine on that. It doesn't have to mean like all or nothing, especially if the medication is helping your overall health. So.
Okay.
Thank you for sharing, because I know I struggle a lot with the semaglutide, tirzepatide battle. It's like an internal battle with myself. And it's crazy because I actually lost faster when I was on semaglutide. Yet I feel like I'm so influenced. I'm like struggling to keep up with paying for tirzepatide.
I caught that TikTok of yours. You're like, I want to de-influence tirzepatide.
Because and it's not, and don't get me wrong, no, tirzepatide is a great drug. I love being on tirzepatide. But I also know that semaglutide is also a great drug. And it also, for me personally, it also worked. So why am I sitting here like so scared?
True.
I don't think we should be scared, but I do think we should keep advocating for better pricing, to be honest, because now that the vials came out, especially with zepbound, they need to do that more. I mean, my patients are really benefiting from the vials, especially my uninsured patients. Like, because before, if you didn't have insurance, you were definitely going to pay $1,300 if you wanted it, right? And if you do have insurance, remember there's those coupons as well. And there's ways that you can, I don't like talking about this online, but you can split the dosing of those many, and that's why they don't want the vials.
Okay.
Yeah,
they don't want you to kind of game the system or kind of get. Yeah, they don't want you to. No gaming. I get it.
Yeah. And I also remember when during the hearing that they had mentioned, I think it was Nordics. They have programs, they say, at least for people who are diabetic to help them
patients
afford the medications. But like you were talking about the vials, and this is just something that I kind of think about because I watch Kim take I think it's an iron supplement with the vial, and I'm nervous about the idea of doing that with a syringe because I don't know, it's just a very nervous thing for me. Just out of curiosity, because of somebody who doesn't do it in any way, shape, or form, are you able to get syringes for the specific dose amount? Like for example, I'm on 12.5 of Tirzepatide, Mounjaro. If I had to move to the vial per se from like a compound, if that was something that I needed to do for pricing, can I get a syringe that just goes to that to that 12.5? Or is it a crapshoot really? Like I got to sit there and try to do it.
So I will say this, I don't actually prescribe compounds, so I'm not a compound expert, so I can't tell you like what the conversion is. I do know it's different because I've heard patients tell me like it's units or something else.
Oh, okay.
But what I will tell you is, unfortunately, Zepbound has not released the 12.5 vials. And that's a problem to me because I have a lot of patients who I started on the vials over the summer when they came out, and now they need more and they're kind of stuck. And that really annoys me because that's not fair to those patients. They're being undertreated. Okay.
Yeah.
So that's why we need to keep pushing them to release the rest of the vials, because essentially what they did is they got everybody hooked up on the medicine and now they're plateauing and they can't get more. And we know there's higher doses. Like I just had a patient who signed up in the marketplace for an insurance so that he can get the pens because he's maxed out on the vials. So it is tricky. So if you were to do compound, I always tell patients on lives, they love to ask me these questions. I say, make sure that you trust your doctor and that your doctor knows what they're doing and they feel comfortable and that they vetted the pharmacy. That is the most important, because if somebody's just giving you a medication and they're not going to manage your side effects or symptoms from the medication, you need to run. That's a red flag, right? And so, they've also made it harder for us to prescribe those medications. One of the reasons I don't do it is because this is when all the legal stuff started. And I was just like, I'm a solo practitioner. I have a small clinic. I can't lose my license, right? Like, because then I can't help anybody. But they have made it a lot harder to prescribe. And so I do think people need to prepare for when that happens. But remember, we didn't have these medications before, and obesity medicine has been around. So I want to leave on a hopeful note that, okay, your doctor should be able to help you manage medications with what other medications we have available. Do you get what I'm saying?
Yep.
So
that's great. I got one more question for you. It's really fun too.
Okay.
Great. I know, like we talked to you last time. Are you still riding on your Peloton?
Sometimes I don't get to it. I'll be honest. I've been really bad at it in the last month. Why?
Because I'm an indoor cyclist too, so I love it. So I just want to.
I do love it though. If I didn't have my kids running around,
we just saw Living Proof.
Mm-hmm. Yep.
Right.
We did.
I have a friend whose daughter got on her mom's high heels and started riding her Peloton, and she caught footage of it. It was funny. It was an entire hoot. Yeah.
No, but
I'd love to see that.
It was adorable.
So I go on cycling classes all the time, right?
I love it. Yeah, I'm training right now not training. I'm getting my butt used to a 100 miler I'm going to do in February. So
Oh, wow.
that's
That's
going to be
so
like 6 hours
fun.
on the bike. So that's
You can
fun
do it.
times for me.
Just put a good playlist on. You can do it.
Yeah. Put on a movie.
And then
Kat's got that.
She's going to do that.
Oh yeah, Kat's got that.
I'm going to get me a bike seat though. I have to put a bike seat and probably wear some shorts with diapers in them. Right.
Well, I mean, don't
that's
they
so
have?
cool. You still ride your Peloton. I love cycling.
Yeah, I love cycling too.
I thought they made shorts for cyclists that had the cushion, like
there's a bike seat in them, and then they feel like diapers.
Wow.
I have one pair of shorts like that. I do have to start wearing one more. I'm starting to get some fat growth in my legs, in my seat.
Ouch.
They're not. It's not painful. It's not painful at all. It's just that my doctor said, I don't know if I should say this because I'm discouraging doing cycling, and it's just because I ride so much. It's like a little lipoma, little teeny weeny. It's like she said, it's my body. You know how like you get a callus on your finger from riding?
Mm-hmm.
That's all it is. It's painless, a little bump. So she said to get a bike seat so it'll go away. So are you still work out?
That's awesome.
Yeah. That's cool. I'm glad you still ride.
Yeah.
I do have one more question. So one of the things that I did on my TikTok was I was interviewing Black men who are in GLP-1 medications. And a lot of that is because a lot of people, like Black people, specifically Black men, like my husband, he's on a GLP-1, but he doesn't have anybody who looks like him.
Oh,
Like to really relate to, like that community is really, really small. And a lot of it is because like, and Black people in general, there's like a lot of medical trauma that comes along with historical medical trauma. So when it comes to new medications, there's always a lot of skepticism. I fell victim to that. That's why I started with Ozempic, because I didn't know what Mounjaro was. It sounded funny. I wasn't trying it. So how, what, as a practitioner, what would be some suggestions that you would have to try and get more people who are skeptical about these drugs, or who might feel embarrassed about being on the drugs, because GLP-1s have been dubbed like a weight loss medication.
Yeah.
And it is a weight loss medication, but it's so much more than a weight loss medication. So as a practitioner, like how would you suggest helping people like?
So my approach to these kinds of situations, because I've been in a lot of them, right? Where anybody who's like, I've had several African-American patients who don't trust me or don't trust the medical community in general. And I get it. Like we did horrible things to them in the past with like, we tested different medications. Like we gave people syphilis, like we did horrible things to people. Okay. So I get it. I think I just like to take my time with those patients, because unless you build some rapport and trust, like they're never going to trust anything you say. And I always give them time. A lot of times I'll plant the seed. And I'll say, this medication works really well for this. It's just a shot. I'll pull out, I have it in my office. I'll have all the fake pens, and I'll show them the pen, and I'll say like, look, this is what it works. The needle is very tiny. It doesn't hurt. You let me know when you're ready. And a lot of times they'll come back and, they'll say, oh, okay, I want to try it. But it takes time. And I think, and sometimes I do refer to some of my minority doctor friends, and I say, hey, can you talk to this patient? I've actually used that technique quite a bit, because it does make a big difference if like you feel like the doctor looks like you, understands you, is not trying to like hurt you. And so I do think that makes a difference. But it's good that people online are talking about these things, right? Sometimes I wish, I'm Hispanic, and I wish I would make more content in Spanish to reach out those patients as well, because minorities do have the highest rates of obesity, but they have the least amount of access, unfortunately. And so we need to change that. And so that's why we need to keep talking about it, right? Because there's all these people that are getting left out of this, like, and who would benefit the most from it. And even whenever you talk about weight with a patient, you have to be careful. And that's actually, I did a talk about this with other doctors. I said, you can't just tell somebody, oh, you need to lose weight. You need to ask them permission if you can even discuss their weight. And everybody looked at me like I was crazy, but it was like, no.
Yeah,
You
no,
have
I
to
feel like
ask.
it's a new thing too, because
Mhm.
I'm 48, and it was the first doctor who has ever asked me if it was okay to talk about my weight. Was my most recent one. When
Mhm.
when did I start seeing her? When I was 44 or 45, and
Mhm.
she laughed at me because I was like, no one has ever asked me this. Like,
Mhm.
oh my gosh. And I just said thank you for about for like 5 minutes. That's just, yeah. So it's
I
very
mean,
new. It's very new.
you have to just be sensitive to that. Like I have patients, I'm in a weight loss clinic and I have patients who don't know their weight because I don't tell them. I weigh them, but we don't talk about it.
I
Uh-huh.
don't talk about it with my doctor anymore.
Mhm.
But my nurse practitioner was the first, no, the second doctor I ever saw that asked me a question before discussing anything with me. Like I saw my therapist for 6 years before
Mhm.
we ever discussed the fact that I'm autistic. And she
Mhm.
said, one, it was because it wasn't going to change how she treated me. And two, she didn't know if it was something that I wanted to know. That I came
Hmm.
to her
Yeah.
for an issue, and that's
Mhm.
what she was going to treat. She wasn't going to just start talking to me about something that I hadn't brought up or wasn't going to affect my treatment. And I thought that was the most amazing thing I'd ever experienced from a doctor. I don't have a
Yeah.
lot of problems with people not talking to me about things in general, or but it's just the fact that somebody cared to ask. That is an amazing thing that doctors are starting to do, and something that I think they need to do more of. So doctors such as yourself, I think, are godsend.
Yeah.
Yeah.
Just promoting that and doing that, because it's the first step.
It's
Asking
changing.
us, do
Yeah.
you want to talk about this? Because there are people like I grew up out in the country, and we don't, in the men especially, we don't talk about our health. I had an uncle, unfortunately, that died on an accident with a tractor, but he went to the doctor for the first time 10 years before that, and they told him that he had all these issues. And when I talked to him after it, he was like, "That's why I don't go to the doctor, because all they do is tell me what's wrong with me." And I'm like, "Dang, I never thought about that." But I guess it's the same reason also for me. Well, I never went too,
And
because
it's also about empowering your patient, right? They have to be a part of the process because yes, I can give you a prescription, but y'all know it's not just a prescription. It's like what you eat, how you eat it. Like are you going to eat your protein? You know what I'm saying? Are you going to stress about whether you can pick it up in the pharmacy, your insurance? Like there's so much to it than just like, here's the prescription. So I always want to make sure that patients are ready for that and understand what they're getting into before we even start. Like I usually meet with patients actually before they even join my clinic and we chat about these things because I don't want them to have like unrealistic expectations. Like most of my patients do lose a lot of weight, but not everybody goes to a normal BMI. And that's okay, right? Because we're also looking for improvement in your health. And there's a
Yeah.
lot of mindset things that we work through and we still have a lot of work to do is what I'm trying to say.
have you ever
Yeah, but I
thought
definitely
about?
feel the change though. I feel like
Yeah, there's
we're getting somewhere. We're moving the needle.
Yeah.
and just one more question for me, because you just kind of made it pop into my head. Have you thought about doing telemedicine?
I do
Because
telemedicine in Texas.
you should expand out. Be-
Oh,
and
to treat John.
I should.
well,
We get
I
patients all the time that find me and they're like in Arizona and all sorts of states. The
well,
only reason I don't do it is because of the kids. I don't
you
have
have a very approachable presence. Like,
Mhm.
even just kind of talking to you in this sense, as well as editing past episodes you've been on, is you have an approachable, easy to talk to nature. And in my experience, at least, I don't know about Kat and Dominic, but that's a rarity in doctors. I normally, when even the nurse practitioner that I've seen for years, I don't feel nearly as easy with a conversation with her as it feels talking to you. Now, grant you, I'm not seeing you in a medical sense, but you just, that approachability, that ease of communication, it's remarkable.
So I think that's a lot to do with how I grew up because I don't come from like a doctor family. Like I grew up around normal people. Like I'm the first doctor in my family. So a lot of it is like when I have to break things down to people, I really have to break it down in a way that everybody can understand, right? Because I have a lot of friends who sometimes when they're talking, I'm like, you realize the patient got nothing out of that, right? You didn't explain it to them in a way that they can understand. So I think some of it comes from that. And although a lot of people don't believe me, I have been a doctor for 10 years. So a lot of it also comes from experience and learning what works and what doesn't. Because one of the things that being a hospitalist has taught me is like, I'm there for like some of the worst things of people's lives. Like I really am. Like, and so you learn how to talk to people and like try to help them see like, okay, I'm here to focus on today. You know, we're going to get through today and we're going to get through this and we're here to help you. And so so I think that's why I appreciate the compliment, but I think there's a lot of things in my background and I wish I could share more on TikTok, but it's hard sometimes because I try not to make it about me. It's about you, the patient. And I take that into the rooms when I go in there. That's not about me. It's about the patient because they're the ones that need the help and that's why they're there to see me. So I try not to, that's why I don't share my personal journey very often because I feel like it takes away from the patient.
Gotcha.
Yeah, makes sense.
I really appreciate you.
Yeah.
I like
Definitely.
it all. You know what? It made me think of. I promise I'll stop. Because I have a niece who is she wants to be a doctor, and I this is something I've realized is probably the reason why like maybe medicine's starting to change a little bit. Because in residency, the doctors kind of take you to the edge of sanity. Right? Like people they're mean. They're awful to you while you're studying medicine. They're terrible humans to the residents.
I remember getting hit by scrub techs when I would scrub into the OR. Yeah. And then the way people love to belittle you, like there used to be this thing in medicine. I don't think we call it this anymore, but they used to call pimping us where they would like purposely try to embarrass us in front of everybody they would ask us questions until we didn't know anything and you just wanted to go in a corner and cry. Like medical training is very abusive. It is getting better, but it's very abusive.
I thought construction hazing was bad. Man, we don't make each other nobody on the construction side ever made me want to cry. I mean, they, threw stuff at me, drove me to want to throw something back, but dang.
Yeah, it's pretty bad. So we appreciate you.
Definitely. And more so knowing that I didn't know that they did each other like that in the medical field. I would have figured it was different. Dang.
Yeah, I mean it's just they try to harden you, I think, because you are gonna do a lot of hard things, right? And so they want to make sure that you're still able to like do your job. Right. So I think that's where it comes from. So if she wants to be a doctor, tell her that it's hard, but she can do it and she'll just need support. It's really nice to have like a family that supports you and like when you're doing it. So, but she can do it.
She can do it. She can do it.
Definitely.
All right.
Do anything.
Well, this has been great.
Definitely. It's been awesome.
Do y'all have more questions? This has been fantastic.
Do you have any more questions? Because this was really easy to talk to everybody. You did great, John.
Thank you. I was very nervous because Kim made me nervous about it. She's like, you have to stay on point because she knows I'll go off in 500 different directions without even meaning to do it. So thank you.
I don't think you went off point. Do you guys think you went off point? I think it was really good.
Stayed right here.
Yeah.
It's all right. I have squirrel moments too. Squirrel.
I hid underneath the porch because I love you.
All right. Well, thank you guys for joining us.
Thank you.
It's been awesome. It was a great talk.
Yes, it was
and we will attach all of your socials to the end of the episodes.
Thank you.
Awesome. I'm just thank you so much. I listened to the podcast like before Kim reached out, so I was like, holy, I can't do this, but I was like, oh my God, me?
She felt so bad that she could not be here for your episode. She started talking to me about the fact that you and another gentleman are going to be on the show, and she got so excited about being able to talk to you guys and be involved in it. So she hated having to not be here today. So I volunteered. I was like, baby, I'll go on in your place. I don't know if I can do as good as you, but I'll go on that way. It's not just
fine.
Cat. Tell her that I really hope she feels better because food, that sucks.
I'm normally the one with food poisoning because I like seafood. So I'm normally the one laying up there like, oh my God, my insides, the alien from Alien, or if you like Spaceballs.
Spaceballs, that one's better.
Yeah, that one is better.
Anyway, I'm sorry. See, there I go. Squirrel.
Yeah.
Squirrel.
Mm-hmm. That's normally what I'm feeling like. So I feel very bad for Kim.
Yeah.
But she'll be okay. She'll be okay. We got her on the brat diet. She's eating some applesauce and drinking water and Gatorade and taking her time. So
that's good. It's a good week after Thanksgiving. I'm being silly, just saying. Okay.
Wicked was really good. If somebody here hasn't watched it, you need to go watch Wicked because I saw your shirt.
Oh, Kim and I went and saw it in New York. So,
Kat, she's seen it 3 more times.
I love it. And I have not seen the movie yet.
The movie, I didn't think I was gonna like the movie.
The movie.
I loved the movie because I've heard so many different complaints, and I'm not a musical man normally. I just the idea of people just randomly going in the scene, I just can't wrap my head around it. But the movie,
for the sake of entertainment, sir.
Yeah. I understand that, but the movie was phenomenal. Actually, I was really surprised that I liked it.
I had seen the play, and then I saw the movie. I agree with him. It blew me. Like I cried like 5 times in that movie. It was so good.
It was amazing. I cannot wait for play. Actually, I told Kim that we can go to New York and I'll watch the play. I was like, because I kind of now at this point in time, I need to know what happens, and I don't think I can wait till November of 2025. So I'm either going to buy the book and read it, or we're going to have to go see the play. It's a one or the other kind of situation at this point in time.
Yeah.
So because until then, my mind is just going to come up with scenarios. So I have to see it before then. So.
All right. Well, thank you, everybody. This has been a fantastic conversation. It's more reason for us to go out there and get loud. You're not alone.
Definitely.
It's not your fault.
Yep.
All right. we're gonna close it up here, and thank you all for listening to us. You like us. You really like us.
You love us, and we'll be back next week.
We'll be back next week. Yes.
Are you interested in understanding GLP-1 medications like Ozempic, Wegovy, or Mounjaro? Then join us on the Plus Side, Cracking the Obesity Code, the groundbreaking podcast helping people change their lives one episode at a time. The Plus Sides podcast is a disruptor. We're breaking down barriers, smashing stereotypes, and sharing inspiring stories that'll leave you feeling informed and empowered. Join us every week to learn from doctors who are specialists around GLP-1 medications like Ozempic, Wegovy, and Mounjaro. They'll provide you with science and facts to validate these incredible stories. But that's not all. We'll also bring you the voices of the GLP-1 Mounjaro TikTok community, real people who face the challenges of obesity-related diseases and disorders and discovered the incredible plus sides of GLP-1 medications. Our episodes are filled with heartwarming stories, laughter, and moments of triumph. You'll connect with our amazing community members who are reclaiming their health and experiencing their fullest lives. Are you ready to embark on a journey of discovery and empowerment? Tune in to the Plus Sides, Cracking the Obesity Code, and together we'll change the narrative around obesity and end the stigma. Subscribe now on YouTube or your favorite podcast platform and join our incredible community. Let's celebrate the plus sides of life together, because every story deserves to be heard. Every life deserves to shine, and everyone deserves access to expert knowledge and medication. The Plus Sides Podcast. You're not alone. It's not your fault.